about what this treatment, anti-VEGF treatment, what it has done on a society level. So please, Michael.
All right, so we're going to talk about the impact of anti-VEGF therapy on the incidence of blindness in countries where such data are available. So in 1994, the World Health Organization projected that the global number of blind people would increase from 45 million to 90 million by the year 2020. It turned out not to be that way. So in 2010, the Global Burden of Disease group was able to show that the rate of blindness had dropped by 42% from 1990. That is the incidence of blindness, a development that was seen in all regions and for both males and females. And most of this was based on the treatment and the prevention of easily treatable and preventable conditions. But age-related macular degeneration was the leading cause of blindness in developed countries at the time, as seen in the graph here. And for AMD, no such easy therapy was available. The Copenhagen City Eye Study examined 946 subjects aged 60 to 80 in 1986 to 88 and re-examined almost all of the survivors again 14 years later, and found that the 14-year incidence of legal blindness from late AMD was 3.4%. And late AMD was responsible for 2/3 of all blindness. So this was data from Denmark. It was known at the time that smoking was a risk factor for exudative AMD, and so smoking could be advised against. And in 2001, the age-related eye disease study, the ARIDS, reported that high levels of antioxidants and zinc as dietary supplements significantly reduced the risk of advanced AMD and its associated vision loss. So dietary supplements could be recommended. And lately, Joanna Seddon's group has shown us something that is very pertinent to our presence in Barcelona, namely that Mediterranean food is also helping you to avoid AMD. So I hope you have time to enjoy that. But there are limitations in implementation. And in Germany, the OCEAN study found that routine use of ranibizumab for AMD was highly uneven between geographical regions. Of 2,658 treatment-naive patients, the delay to the first injection from the first examination to the first injection was 20 days, and it varied considerably between district types, and services were poorer in rural than in urban settings. The main regional disparities are therefore very important, and there is definitely a public health obligation to do something about this, not only in Germany, in Denmark as well, and most other countries, I guess. In the UK, the incidence of blindness was examined then in patients who underwent injection treatment for wet AMD. We are about 1.5 decades later, 11,135 treatment-naive patients, and they were treated with 3 monthly injections for loading, and then intended follow-up was monthly with PRN treatment. The mean visual acuity at baseline was 20/40. Blindness was defined as 0.1 visual acuity or worse. And the cumulative incidence after 1 year, 2 year, 3 year, and 4 years after the first injection were 5, 9, 12, and 16%. So there was a constant increase with increasing intervals after the initiation of treatment. This compares favorably with a 29% progression to blindness seen after 2 years in an untreated UK cohort from Gloucestershire that was examined in 2002. And the UK study also showed that the visual prognosis has improved with time after implementation. So doctors and healthcare systems are getting better. They retain more vision and avoid blindness to a higher degree, counted from the first injection. We also have data from Scotland, a 5-year follow-up study after the initiation of intravitreal ranibizumab for wet AMD, showed that blindness rates peaked at 9.1 cases per 100,000 inhabitants in 2006 and fell to 4.8 cases in 2011. So there is ample evidence that it can be done in more than one country. Let's look at the third one, Denmark, where anti-VEGF therapy for wet AMD was begun in 2006. The strategy was 3 loading injections and then PRN. The mean visual acuity at baseline in injected eyes was around 0.2, 0.25, and blindness was defined, as we just saw it, 0.1 visual acuity or worse. The annual number of new cases of blindness were obtained from the Danish Association of the Blind. This is not a public, compulsory registry, so there are limitations in it, but it shows some interesting time trends, which we have here. So the incidence rate of legal blindness has decreased dramatically from 2001 to 2016, which are the latest data. And obviously, the avoidance of smoking, the decreased smoking rates, better diets, dietary supplements may have had an effect. And indeed, the average life expectancy is increasing in Denmark, so people are probably living a healthier life. But we do see that something drastic happens after 2006, when anti-VEGF therapy was introduced, as it did in Scotland and in the UK. It's also very nice to see that blindness from other causes combined is steadily decreasing. So what did it take to get there? It took a lot of injections, and the injection activity was ramped up in a very impressive way, in my opinion, especially in Copenhagen. What I'm impressed about is that we got the money for it and that we were able to organize it. And if we look at the very latest trends here, where we have figures for the first half of 2017, then it looks like the injection rate is being stabilized. And this was to be expected now, 10 years out after the introduction, because the average patient is an 80-year-old person, and the average life expectancy when you have reached the age of 80 in Denmark is 10 years. So we should begin to see the coming and going being about the same for this population. So what have we shown? Since the introduction of PDT and intravitreal VEGF inhibitors for wet AMD, the AMD-specific incidence rate of blindness has decreased by 70%. The bulk of the decrease occurred after the introduction of VEGF inhibitors in 2006. Blindness from other causes also decreased during the same period of time. The injection rate looks like it has stopped growing, which is important for health economics. Progress has been made, but maybe more could have done. We have not proven by any means that we did enough, and I think there's still room for improvement. AMD still accounts for more than half of the new cases of blindness, and the trend is that there is no more improvement, or less than we had in the beginning. So the fight against blindness looks like it is coming to a standstill, which is a serious business and serious issue. And worse, there are many places in the world where smoking is still very common or even increasing, especially in Asia, I have heard, and especially among men. So take that message home if you're from Asia. And worse, figures for blindness in children show that the incident rate is increasing. This, we have very good data for that from the UK, and similar trends have been seen in Denmark, and this is mainly driven by hereditary retinal dystrophies, cerebral visual impairment, and nystagmus. So what more can be done? Well, we can continue the fight against smoking globally. We can improve dietary habits, We have lots of patients' contacts and lots of opportunities to motivate patients. We can implement better to reach the last patient with wet AMD and to do it in a timely fashion. We can develop treatments that are easier to use, and industry is working on that, we know. We can develop imaging options that are more widely available, easily accessible. We can provide better documentation for the cost effectiveness of VEGF inhibitor therapy to defend continued spending. And with that, I will thank you for your attention.
Thank you very much, Michael. Do we have questions from the audience?
Maybe I have a first question to start with. Could you quantify the effect of smoking? Do we have any data of this? Would this be a significant reduction in the blindness rate? Could we show this?
I think it could be shown. I don't have the estimates ready for you, but there is so much else that can be achieved by the avoidance of smoking. So it's a win-win, win-win, win-win-win situation. You can't do anything bad by discouraging smoking.
Well, doctors always like to blame the patient for everything. But if we look into our own providing of medical care, have you any data on the development of the equality of access to anti-VEGF treatment? You showed some interesting data from Germany where you showed that this treatment was more accessible in cities than in rural areas. Has that improved?
We have data that I didn't bring here because I didn't want to have more enemies in Denmark. No, I mean, it's a controversial issue because we know that there are regions where patients are underserved, and clearly something should be done about it. Unfortunately, people with sight-threatening conditions do not have strong advocacy groups. Cancer patients and cardiovascular patients have strong advocacy. And we need to look into this. We have discussed this internally among some of us in Denmark, and I think that maybe people at the highest level of the healthcare hierarchy are in the best position to do something about it. I think it would be, it may stir up more conflict than progress if we take it to make a public fight out of it. But there are inequalities of access in all countries, including Denmark. Okay. I think maybe something can be done about it. Those who are best suited to do something about it are our colleagues in private practice, in general ophthalmology practice under the Danish healthcare system. They now have OCTs, almost all of them, excellent equipment, and digital communication of images has improved so that it has now become practicable. And they are the ones who can really put pressure on the system by telling their patients that now you have wet AMD, and the standard of care is that you should have an injection within 2 weeks.
Okay.
Thank you very much for this excellent talk.